bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities.
All right, hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Paediatric Health Centres. And today's webinar is titled The Zika Virus, a Global Issue in a Canadian Context. All right, so as it says in the title of the webinar, today is about putting the Zika virus issue into context for our Canadian child and youth healthcare community. And I think everyone recognizes that, you know, from the perspective of a Zika virus epidemic in Canada, that's highly unlikely based on climate and types of mosquitoes and all the other things we hear about on the news. But last year we saw during the Ebola crisis, these global health issues often do have an impact in Canada, both on healthcare providers and organizations as they try to deal with information or lack of information. And we saw, the absence of good evidence or at least factual information during the Ebola crisis, or possibly even the presence of sensationalized news media. We did see a reaction from the healthcare community that many would agree might not have been the most efficient or evidence-based response in some cases. So today's presentation is just about getting good information out to the community as far in advance as we can of any reactions that we might see. So today we've got some great presenters that are going to bring us that information and hopefully answer any questions that you might have. So our two presenters, first up we're going to have Dr. Jonathan Goubet, who's a medical microbiologist for the Virus Detection, Arboviruses and Respiratory Bacteriology Laboratories at Public Health Ontario, and is the laboratory lead for emerging viral pathogens at PHO Laboratories. He's also an assistant professor in the departments of laboratory medicine and pathobiology and pediatrics at the University of Toronto, and is a part-time staff physician in the Division of Infectious Diseases at the Hospital for Sick Children. And our last-minute addition is Dr. Kelly Murphy, who comes to us from the Department of Obstetrics and Gynecology at the University of Toronto, where she is currently an associate professor, and is also a physician based out of Mount Sinai Hospital. She also holds a joint appointment with the Clinical Epidemiology and the Department of Health Policy Management and Evaluation at the University of Toronto. So without any further ado, it's my pleasure to hand the virtual podium over to Dr. Murphy and Dr. Goubet. Over to you.
Thanks a lot, Doug, and thank you for everyone who's joined today. So we're going to try and give you an overview of the Zika virus. I'm sure everybody's been hearing about it in the news. And as Doug said, we're going to try and clear up some of the misconceptions and bring everybody up to date with what's happening. I just want to mention that literally 30 seconds before we started hearing some construction noise above us. So if, Doug, just let me know if it's better that we pick up the receiver if that noise is coming through. Okay, so just a quick talk outline. So we're going to review the virology and clinical features of the Zika virus. We'll give an overview of the epidemiology and how it spread to the Americas, which of course led to Zika being in the news, and the main trigger to that was these potential associations with congenital infection, in particular microcephaly and cerebral malformations, but also a syndrome called Guillain-Barré syndrome. We'll also have a look at the laboratory testing guidelines for Zika virus, and then I'll be handing over to Kelly, who'll give us a nice review of the approach to a pregnant patient who's travelled to a Zika endemic area and what should be done there. And then we'll finish off just outlining our prevention strategies. So some virology, and sorry if this is not relevant to some of the people on the line, but Zika virus is in a genus called flavivirus in the family Flaviviridae. Other examples you may have heard of West Nile virus, most people in Canada would have heard of that, and dengue virus, yellow fever virus, and Japanese encephalitis virus. The most closely related virus is one called Spondweni virus that can cause fever and has been found in Africa and Papua New Guinea. And just looking at the viral structure, it's what we call the single-stranded RNA positive sensor virus, and has a lipid envelope. It's quite a small virus, and it's about 50 nanometers in diameter, and it has what's called icosahedral symmetry, which basically means it's sort of soccer ball shaped. So the virus actually was first detected when doing research in a forest, called the Zika Virus in Uganda. It's a forest that's only about a mile wide by 500 feet, and what they did, they had monkeys on platforms, and they left them out there and then sampled them to see if they were growing any new viruses, and they discovered this virus that they named after the forest, Zika virus. And then subsequently was first reported in humans in 1952. The first country that was found in humans was in Nigeria. In terms of how the virus is spread, so it's mainly transmitted by mosquitoes in the Aedes genus of mosquitoes. So there are several that have been found. The main one is the Aedes aegypti. One concern is that in at least one review, they did find it in Gabon in 2007 in the Aedes albopticus. The reason why there is concern with it being in that species, that that virus is much more widespread in the Americas, in particular in the United States of America. And this is just a snapshot of that very first publication in 1952 when they reported the discovery of the virus. In terms of incubation period, so it's 3 to 12 days, could be up to 14 days. With the limited data that's available so far, it appears that only about 20% of infections are symptomatic. And it's usually a mild self-limited illness with maculopapular rash, which just basically means a red blotchy rash that's a little bit raised. And that would be the most common symptom. You can get a low-grade fever, you can get conjunctivitis. As you can see here, it's a redness of the conjunctiva, but not actually like pusky discharge that you sometimes would see with other types of conjunctivitis. And then you can also get an arthralgia, so pain in the joints or joint swelling. Most people recover within 5 to 7 days of the illness. So there have been some reports of human-to-human transmission of the virus, and that is creating some concern. So up until yesterday, when there was some new information out from the CDC, there'd been 2 definite documented cases of human-to-human transmission, and the virus had also been isolated from the semen of a male patient who was diagnosed with infection but hadn't actually had sexual contact. And it appears that the virus is detectable in the semen longer than blood. We have received unofficial communication from Public Health for England of them identifying it in the semen of a patient approaching 2 months after illness onset. But we don't really know what the outer period, the maximum sort of period of time is, and that's still ongoing in terms of being investigated. There are also several reports under investigation from Brazil of blood donation resulting in transmission of the virus, and another theoretical risk would be organ donation. The virus has been found in breast milk at the genetic level, but they haven't been able to actually grow the virus from breast milk, and there's been no evidence of breast milk transmission, and all the current guidelines are very clear that breastfeeding should not be stopped if a woman who's breastfeeding gets acute Zika virus infection. We also can find the virus in urine, saliva. It's also been detected in nasopharyngeal swabs, but neither of these sites have been implicated in transmission. So, as I said, the virus was first found in 1947 in Uganda, and then by 1952, 1954 was in Nigeria. Then after that, we started to see some reports in different countries in Asia, including India, in Malaysia by the late 1960s, and wasn't really heard about a lot in a big way in the intervening years. And then in 2007, there was an outbreak on Yap Island, Micronesia. It's a very small island. I think there are only actually about 80 cases, but it was big news and like amongst the infectious disease community, and that was communicated pretty broadly. And then subsequent to that, in 2013, there was an outbreak in French Polynesia. And then that resulted in other surrounding islands having cases. So in the Pacific Islands, including New Caledonia, the Cook Islands. Then Easter Island is sort of documented as the first place in the Americas where there was the first autochthonous, which means transmission from like locally acquired case of the infection, and that was in February 2014. And from there, it made the jump into Brazil from late 2014, early 2015, and then into other countries in the Americas. When they've done molecular sequencing of the virus, it's shown to be the Asian lineage of the virus that's causing the current outbreak in the Americas. There was a recent publication from some researchers here in Toronto. The first author was Isaac Bogoch, who's here at University Health Network. And what they did was they showed the potential spread of Zika virus to the Americas. They also looked at Europe. And the areas shown in orange are where they using modelling, they showed that you would expect a year-round transmission of the virus. Where it's a yellow, you'd see seasonal transmission. Where it's white, you wouldn't expect much transmission. That's where it's a more temperate climate. And these circles were showing the amount of travellers to each of the areas. So it sort of made sense that we were going to see this spread. And from 2007 up to mid-February, we've now seen the virus in 48 different countries, and you can see from October onwards, October 2015 onwards, the rapid increase in the number of countries that are seeing cases. This is just a WHO map that shows you all those countries that have had cases. So it includes some in Asia, but predominantly here in the Americas now. And then in Brazil, as I said, in late 2014, they started seeing cases. It was May 2015 when they first confirmed that this was Zika virus. Using PCR molecular methods, we were identifying the gene target of the virus. They stopped doing formal counts, like due to the fact that they just couldn't keep track, but have estimated that up to about 1.5 million cases have occurred there since the outbreak started. And then the other thing that we're all aware has raised concerns is an increase in the reporting of microcephaly from Brazil. So they had over 5,000 cases reported between November 2015 and mid-February, and it included 108 deaths within that group, and their average was only about 160 or so per year between 2001 and 2014. There's currently ongoing investigation of these cases. So far, they've in the latest report from about a week ago from WHO, they've gotten through just over 1,300 of the cases. And as you can see, there's probably been a lot of misclassification about microcephaly, which is usually 2 standard deviations below the mean, or some people would use 32 centimetres. And they threw out 837 of the 1,345 cases, and but confirmed 508, and then have looked more closely at 460 of them, and of them, 420 of them have radiological findings that are consistent with a congenital infection, and just under 10% of them do have lab confirmation of Zika virus infection. As I said, this is still an ongoing investigation. Amongst the 108 deaths, where the infants died either during after childbirth, or if it was a fetus that died during pregnancy, they confirmed 27 as having microcephaly or CNS malformation. 11 of them were discarded as not being related to possible microcephaly, and 70 they're still investigating. And I'll just say that other countries, the other place that have reported some microcephaly is in French Polynesia, where they reported 18 cases. With regards to Guillain-Barré syndrome, which is basically thought to be an immune reaction to a trigger-like an infection, where the immune system attacks the peripheral nerves and causes ascending weakness or paralysis. And so several countries have reported an increase. I've got them listed there: Brazil, Colombia, El Salvador, Suriname, and Venezuela. And also they were reported in the French Polynesia outbreak of 2013-14. In Brazil, they've seen a 19% increase if they compare to their annual tally of 2014. So based on the suspected link with Guillain-Barré syndrome and microcephaly, the World Health Organization convened a meeting, and on February the 1st, they declared that it was a global public health emergency. They actually, I think there was a lot of like controversy about that, and some people felt like they were just sort of reacting, like it was reactionary after they were criticized for being late with calling Ebola a public health emergency. Some people thought they were sort of calling this a bit too early. And then several of the people who were actually on that committee then wrote a joint letter to the Lancet, and the first author is David Heyman. And they explained that the reason for this being called was different to Ebola. They said with Ebola it was an issue of a virus that was already well understood, that was occurring in large scale. Here it's about a suspected association with a complication of the virus that needed to be better understood. But it was interesting to see that they felt they had to come out and sort of defend what they'd done. I'm actually just going to switch now to cover a bit on the laboratory testing for Zika virus. So the main testing modalities, the best test is PCR, where you're actually confirming detection of the virus, the genetic material. Alternative ways of making a diagnosis are using serology. There are two types, one called IgM, which is a bit more straightforward. The other one called plaque reduction neutralization titer, it actually relies on growing the virus and seeing if the patient's antibody can inhibit growth of the virus, and that actually takes a week to do. Other ways that can be done is if you detect the antigen of the virus, say with pathological stains. Currently that's not available in Canada, but is in use in the United States. And some people have developed rapid tests for detecting the antigen of the virus. Virus culture can be done as well, but it's not a routine method of diagnosing. In terms of laboratory correlates for case confirmation, it's basically if you're able to grow the virus or detect its nucleic acid or the antigen in a clinical specimen, or if you're able to detect the IgM antibody together with a parallel specimen tested by this plaque reduction neutralization titer assay. And that's because the IgM alone is not enough to diagnose Zika virus. You get, because the flaviviruses are similar to each other, you can get cross-reactivity and false positive IgM to the Zika virus if someone was previously exposed to another flavivirus. And the main flavivirus that's on the differential diagnosis and is circulating in the same areas is dengue virus. It's more a problem with people who live in the endemic area, is that a lot of them will be IgG positive for dengue virus, and a lot of these people who are being tested for Zika, the illness actually might have a mild form of dengue. And another way of diagnosing the infection is on a CSF sample, if that was done as part of the investigation, say of a microcephalic neonate. So the current PCR that's being done at the National Laboratory, and some of our provinces are rolling it out. We're working to set it up here in Ontario. It has two targets. One is at the envelope gene, and another one at the junction of the envelope and membrane protein genes. If you get a positive PCR test, that's enough for confirmation. The limiting factor is that you have to collect the sample early in the period of symptoms, because people are only viremic for, it's currently thought to be for about 5 days. We test up to 10 days of symptoms. I believe there have been isolated reports where it has been detected even longer than that, but some of those patients were immunocompromised. That PCR testing can be done on blood, can be done on CSF tissue, and also can be done in urine. And there is some evidence that the urine stays positive for longer than the blood. So this slide pretty much repeats what I just went through. And when they have investigated, I did mention that it has been detected in serum beyond that period when the serum becomes negative. But do want to reinforce that in the current testing guidelines, it's not recommended to test semen at all. And I'll go into that as we get to it. When doing serology, it's important to try and get an acute serology at the time of initial presentation. You might not have the IgM present at that time, but if you're doing a follow-up convalescent sample 2 to 3 weeks later, then you hopefully will document a seroconversion going from negative to positive, or an increase in the what we call the titer of the PRNT antibody that the patient has. And it's important to note that a negative serology test does not rule out Zika infection. We really don't know the exact sensitivity of serology at this time. This is stuff that I've just mentioned about cross-reactivity, so I'll skip that slide. And then again, the PRNT test, which we said was a confirmatory one, that one also can cross-react amongst the flaviviruses, so it's not a clear-cut, easy interpretation when doing the serology. So what they have to do is run the PRNT test to Zika virus, but also in parallel run it against dengue virus, which is the other main flavivirus that we'd be considering. And the titer of the virus for Zika virus, which is like the dilution of the patient's antibody that will still inactivate the virus, that's called the titer. It has to be at least 4-fold or greater that of dengue virus to say that this is confirmed as Zika infection. Otherwise, we call that a inconclusive serology. This slide I'm going to skip. It'll be a nice reference for people. So I'm showing it now here as an example of what we have done in Ontario. Obviously, I know people are dialed in from across the country, but I'm sure that your province will have guidelines on their own websites as well. So we have what we call a test information sheet that gives a lot of the information that we need. We have a list of mandatory requirements, and we've actually developed a form that is linked to within that site. And so we need the countries visited, the dates of travel, onset of symptoms, the date the sample's collected. We need to know whether someone's previously had a documented flavivirus infection or if they've received one of the flavivirus vaccines. So in particular, that would be yellow fever vaccine or Japanese encephalitis vaccine, because if they do get a positive, the lab, at the national lab, they would then go and run in parallel to those flaviviruses in addition to dengue. With that bit of additional information. Of course, we want to know if patients are pregnant because that would help prioritize those samples for quicker testing. And then if you know, it's a case where there's a fetus or a neonate involved, any information that's available from that ultrasound will also be helpful. And we've actually developed a really, I think, helpful table that is also linked to in that document. It goes through each of the scenarios where you may consider testing and tells you what tests we think you should order and what will and what won't be accepted. So everybody's welcome to have a look at that. I've provided links to those, but I think they are very helpful for the primary healthcare provider. In terms of a symptomatic patient, the test to order would be serology and PCR. We also will do chikungunya and dengue serology, and that's just to look for other viruses that are circulating that could give a similar clinical presentation. On exceptional circumstances, we can ask the national lab to do chikungunya and dengue PCRs as well to diagnose those acute infections, but usually they can be picked up with serology. However, if it's a patient in ICU, or say it was a pregnant patient whose serology was indeterminate, but we do have a sample that was collected early in the symptom period, we could add those tests on to help clarify whether it's a cross-reactive serology to dengue. I just want to stress also the serology cross-reacts with dengue, but chikungunya is an alpha virus. It's in a different family, so it doesn't cross-react with that virus. And then for asymptomatic pregnant patients, we just need people to order serology. They don't need to order molecular testing because it has no real role in an asymptomatic patient, as it's very unlikely to be viremic. CDC has said that a negative IgM at around 2 to 12 weeks after the last exposure would be reassuring of someone not being infected, but doesn't totally rule it out. And we also want to stress that patients who are not symptomatic, i.e. if they were never symptomatic or were symptomatic and have now recovered, should not be tested and actually won't, their samples won't be received for testing. And that includes for people that are wanting to be tested to like clear themselves before conceiving. And the reason for that is that for a start, we suspect that the virus is present longer in the semen than in the serum, and it's just not practical to go and do serial semen PCRs on every male traveller that went to an endemic area that comes back and wants to get his partner pregnant. So the current guidelines are to use condoms for a period of 2 months after returning. But if your partner is pregnant, then the Canadian guidelines still say 2 months, but they say you may want to do the duration of the pregnancy. And I'll show you a slide in a minute. This slide, as of yesterday, CDC announced another 14 cases that they're looking into for possible sexual transmission, and they did put out what we call a COCA alert, where they put out alerts to practitioners, and they've said that they've confirmed in 2 women infection. 4 of them, the women are IgM positive, and they're waiting on the confirmatory serology, and another 8 are still under investigation. But they did point out that all 14 of their male partners did have symptomatic infection. So it does not appear that an asymptomatic male is transmitting the virus, but obviously it's still early days to say for sure. And I'm just going to finish up by showing some quick slides just to let you know that there are some commercial assays for these serologies. The ones that have been done so far were developed in-house at the CDC and have been brought online at the national lab. But these could potentially replace the very labour-intensive PRNT test, which is predominantly measuring the IgG antibody. So the national laboratories just received these kits, I think, yesterday. We should receive them as well very soon. I'm going to start evaluating them in our lab in Ontario as well. And these may help speed up testing. The early data is that the IgM test appears to be more specific, so less false positives, but maybe not as sensitive as the in-house test. So in my head, I'm thinking maybe for a pregnant person, we wouldn't rely on this, but for everyone else, we could probably use this and get a higher throughput. There are also some commercial assays for the PCR testing. Here's just one as an example, Altona. It's a company in Germany. And then this is a company in Canada that's developed an ICT or antigen detection kit, but it's not Health Canada approved, so not really out on the market. So I'm going to hand over now to Kelly, who'll carry on with the presentation.
Thank you, and thank you, Jonathan, Doug, and thank you for inviting me to participate today and to talk about the management of the pregnant patient in regards to Zika virus. So, as everybody is certainly aware, that this is big news in the pregnancy field, that our pregnant women are actually up in arms and nervous, and it's a bit of chaos in our clinics for women who are traveling abroad. And as I'm sure people have seen headlines like this: pregnant Canadian woman who initially refused a Zika test after visiting Brazil is thinking about interrupting her pregnancy. Luckily, she went on and was tested, etc. But long and the short of it is, it has created a bit of chaos in all of our practices. Let me just tell you a little bit more about that. And why, and it's because of the association of Zika virus and microcephaly. So here's a drawing, and as Jonathan said, we're microcephaly being defined as fetal head circumference at least less than 2 standard deviations below normal, or less than 3rd percentile or 2nd percentile, a variety of definitions people are using. And visually, this is what we're talking about. I'm sure people have seen this in the news. So I just wanted to go back a little bit to review some of the pregnant, a couple of the first pregnant cases. So this was, these 2 cases came from an article in Ultrasound Obstetrics and Gynecology in January. So Zika virus, intrauterine infection causes fetal brain abnormality and microcephaly, tip of the iceberg. And so the first 2 cases were from this northeastern state, Paraíba in Brazil. In both cases, Mother's blood was negative for Zika. I'm not exactly sure what that means. They did not describe it in the article, so I'm guessing perhaps serology or I don't know, maybe it was PCR. The amnio was positive for Zika, and certainly that was PCR. No description of maternal symptoms or pregnancy outcomes, but the genotype in both cases was of Asian origin. So just let me tell you about the first case. So the first case of fetal abnormality was diagnosed at around 30 weeks gestation. The baby's weight was 21st centile, and fetal head circumference was about 2 standard deviations below normal. And on ultrasound imaging, it showed brain atrophy, intracranial calcifications, absent corpus callosum, and cerebellar vermin dysgenesis, large cisterna magnum. So just visually, just show you everybody what that sort of looks like from our perspective. So again, you can see calcifications, you can see an absent corpus callosum, more calcifications, interhemispheric space here, so representing CNS atrophy, more calcifications. In the second case, again diagnosed on ultrasound around 29 weeks. So again, you know, from my perspective, it takes time for these, you know, if this is the secondary to Zika and the infection, which is looking more and more suspicious, it takes time for these anomalies to evolve. So saying baby, you know, baby was exposed in the late first, second trimester. Again, estimated fetal weight 20th centile with the fetal head circumference, you know, below the 3rd centile. So on the second case, you will see they saw marked asymmetry of the ventricles, ventriculomegaly, thinning brain parenchyma, loss of corpus callosum, and absent thalami, calcifications, and cataracts. So again, you can see the asymmetry here between the two ventricles. You can see this large dilated ventricle, calcifications, and here, if you can see here, sort of the orbits, so the baby's orbits, nose, and here you can actually see calcifications of or cataracts. Subsequently, in that report, they described 6 other children diagnosed with Zika infection at birth. Mothers all had symptomatic infection in pregnancy. I'm sorry, just like the other 2 mothers had. I'm not sure if I said that clearly. So all 8 cases in this case report, all mothers were symptomatic. All babies had head circumference less than the 10th centile on neonatal exam. Postnatal imaging showed that 2 infants had cerebellar involvement, 3 had brain calcifications, and 1 had severe arthrogryposis or newborn contractures. Then recently, so February 10th, in the New England Journal, there was a case report of a young European volunteer who was in Natal, Brazil, so northeastern Brazil again, volunteering there, developed a fever at 13 weeks gestation, a musculoskeletal pain, eye pain, and had that maculopapillary rash, and she tested positive for Zika virus. She underwent ultrasound examination at 14 and 20 weeks. She returned, and which were normal. She returned to Europe at 28 weeks, and unfortunately at 29 weeks, on ultrasound, abnormal findings were seen. So then follow-up assessment at 32 weeks, fetus was found to have intrauterine growth restriction less than 3rd centile, and the head circumference was noted to be less than the 2nd percentile. Placenta was thick and calcified, moderate ventriculomegaly, and intracranial calcifications, decreased movement, etc. And she underwent interruption of pregnancy at 32 weeks. Again, a few pictures of those ultrasounds. So again, multiple CNS calcifications, ventriculomegaly, and here you're seeing placentamegaly, or very fat placenta. This is from the autopsy, and again showing calcifications, agyri, and also ventriculomegaly here. And this is, again, from the autopsy. This is a microscopy of the Zika virus, and the same Asian strain found in Brazil was isolated from the fetal CNS. So again, autopsy here, baby was 5th centile, head circumference was 1st centile. Microcephaly, interesting, was the only external anomaly identified. So again, but on microscopy and all the other findings, so complete agyri, and you can read through the list of significant CNS findings. And again, as I said, brain tissue positive for Zika, PCR, negative for the other viruses, our torch viruses, so toxo, rubella, CMV, herpes. And again, genotype, Zika Asian type seen in Brazil. So since that outbreak, they've developed a Zika embryopathy task force in Brazil, which is made up of a variety of specialists, so obstetrician, geneticists, pediatrics, neurology, radiology, to investigate all the cases of microcephaly. And I think actually Jonathan was giving you the update on some of those cases. But this is from one of the first tables, and I think he's got maybe more updated slides. But for me, what was interesting was just that reported maternal rash. Again, women appear to be symptomatic, in the 1st and 2nd trimester, predominantly the 1st trimester in these cases. And again, this makes sense to me in thinking about other viruses, things like CMV, toxo, etc., that when fetuses are infected in utero, particularly in the 1st and early 2nd trimester, is associated with some of the worst outcomes for the baby. And again, the same case series. So this is a small series of 35, about 35 babies. And again, all of them having small heads less than the 2nd or 3rd centile. 50% having neurologic abnormalities on examination as a newborn. But just acknowledging potential limitations of the data so far that we have. So historically, rates of microcephaly in Brazil were reported to be at 0.5 per 10,000, which is about, lower than world average. So we would usually talk about rates of 1 to 2 cases per 10,000. So perhaps there was under ascertainment of microcephaly prior. The current rate now in Brazil is about 20 per 10,000. Head circumference previously was not routinely measured in Brazil on newborns. So, there's questions about that. Not all these cases, women had the opportunity for serology testing for Zika, and the rash could be nonspecific. So again, we wonder about recall bias or misclassification bias. And there's no comment in these reports about other findings of these infants. So discussion about hepatosplenomegaly, other rashes, chorioretinitis, etc. So we have a lot to learn. So what about recommendations? First and foremost, pinch of prevention's worth a pound of cure. So the American College, the Canadian College of OBGYN, first and foremost, we're telling our women not to travel. Interestingly, in my own practice, this has been a hard pill to swallow for some of my women. Even some of my women who are healthcare providers and physicians are unhappy when I've told them to reconsider their March break plans. That some people are pretty disappointed. This virus has thrown a wrench in many people's plans, and that number of involved countries appears to be growing and growing. The other thing we are saying to our mothers is that if you have to go, if there's no option, you have to go. Protect yourself, and I would say this traveling to Latin America or the Caribbean, but I'd also say this going to Muskoka in the summertime. I tell my women is cover up, make sure that you protect yourself from mosquito bites. Absolutely, wear bug repellent with DEET. Women very often are reluctant to do this in pregnancy. They don't want to take a Tylenol, drink a coffee, or color their hair, but yet they would expose themselves to these potential viruses. So we really do push our mothers to wear bug repellent when appropriately. And obviously, make sure that your sleeping quarters, you've got screens on your windows, etc., the usual things. This is a schema from the CDC talking about women. Primarily, I think this is useful for the asymptomatic pregnant women as far as management goes. So for women who have been to an endemic area where they return and have history of symptoms, if it's within the 10 days of returning and within 10 days of those symptoms, we would send their blood for both the PCR and serology. If they just were symptomatic, we would absolutely send it for serology. And in fact, we're sending all women who've been to those areas, ideally within 12 weeks. We are testing for serology for Zika virus. If it is positive or inconclusive for Zika, so the IgM is positive and the PRNT is positive or inconclusive, we then are recommending that women are referred to either maternal fetal medicine specialists or infectious disease, obstetric infectious disease specialists, that they consider serial ultrasounds every 3 or 4 weeks. And then there's this consideration of amniocentesis for Zika. And I say consider simply because, again, we don't know how good amniocentesis testing is. Certainly in the case, if, heaven forbid, you would find anomalies or have findings that were concerning, we would encourage amniocentesis. I've had some communication with one of my maternal fetal medicine specialists in Brazil, and who's told me that some of the amniocentesis testing has been disappointing. So I think cases where they're confident that women had Zika, but the amnio was negative. So, and they've had findings of anomalies. So I think we still have lots to learn about testing for this challenging virus. In the other case, on the other hand, if people are tested and it comes negative, patient tests negative for Zika virus, still would recommend ultrasound, some ultrasound assessment to rule out calcification or other anomalies. If it's present, if heaven forbid there's presence of abnormalities, clearly those women would also be referred to the maternal fetal medicine specialists or geneticists. In the case of when there's normal ultrasounds, essentially they'd go back for routine care, but there's current discussion right now amongst the Society of OB/GYN Canada as far as trying to figure out what is the proper follow-up screening for these women, in the sense, as Jonathan said, we're not sure about the sensitivity of the current serology testing. So even though women might test negative for Zika, we're not completely confident that we can be completely rest assured. So again, depending on proximity, if she tested negative and timing, you might choose to repeat that testing, or you might choose to follow up with an additional ultrasound just to be extra safe. What about the newborn? So in my, I have not come across one of these cases yet, but evaluation of the newborn, clearly in my case, I wouldn't be doing this evaluation. I'd be phoning a friend at Hospital for Sick Children or one of my pediatric colleagues. But for a newborn born to a mother with confirmed Zika or signs of congenital Zika virus, we would refer to an infectious disease specialist. At delivery, we would try hard to get either blood from the baby or from the umbilical cord for PCR and serology. We'd want to send the placenta for PCR. And if the baby underwent a further assessment and cerebral spinal fluid was obtained, we would send PCR on that as well. We would want to obtain CBC and liver enzymes on the baby, do a hearing and eye exam, head ultrasound, and perhaps cerebroneural developmental examination. So everybody has been weighing into this debate, and even the Pope most recently, late last week, or I guess late last week, was saying that giving people permission to use contraception in endemic Zika areas, suggesting that avoiding pregnancy is not an absolute evil, that actually there are worse evils, and I think he's referring to abortion, which is all very interesting. And today I read in my OBGYN news that in Colombia that the whole Zika epidemic has sparked new debate about abortion, and that they've actually come out and said that in Colombia that having an abortion for Zika virus was acceptable. So huge uproar around the world. I do have to say that amongst those of us who also spend time taking care of women who are HIV positive in the whole HIV field, I find this a little bit irritating in the sense that Zika is terrible, but HIV has killed millions of people, and babies are stillborn every day who are HIV positive. But I'm hoping this is all a step in the right direction, that he'll be compassionate for Zika, that maybe the people and the Catholic Church will be compassionate for contraception around the world for other viruses as well. So I thought I'd just quickly end with a couple of cases. First case is a 32-year-old woman who we see at 22 weeks, who's returned from her grandma's funeral in Venezuela 1 week ago. A few mosquito bites, no history of illness. So should she be screened? Absolutely yes. And we would do serology testing because she's asymptomatic. So in this case, she had an ELISA test, an IgM, and it was positive. And then she did her PRNT and it was also positive. So how should she be managed? So we would refer to a maternal fetal medicine specialist or an OB with who is an infectious disease specialist. We'd continue to do ultrasound assessments every 4 weeks, and we would consider an amnio, particularly if we saw signs of fetal infection. Second case, a 30-year-old woman at 29 plus weeks who's relocated from Guatemala to Canada 1 month ago, secondary to the Zika scare. She recalls numerous mosquito bites. Should she be screened? Absolutely, she should be screened. Again, serology testing. Her testing, IgM negative, and her PRNT be negative. How should she and her pregnancy be managed? So in her case, we would recommend back to essentially routine care. We're not going to be able to send everybody who has a negative serology to an MFM. They should go back to routine care, but we would consider an additional ultrasound, say perhaps at 30 to 32 weeks, and perhaps maybe again at 36 weeks. Again, this is where, as a nation of experts in the Society of OBGYN Canada, where there is some discussion about how we should follow these women, primarily appreciating that different women have different access to ultrasound assessments, etc., depending on where they are, etc. So we are still finalizing our guidelines, but hope to have those out very soon. Finally, a third case, a 27-year-old woman at 16 weeks returned from her baby moon in Martinique. For those 6 weeks ago, for those of you who don't know, baby moon is a new term that I've heard in the last year or so, where people try to take a holiday before they have their newborn child for a break. She recalls getting a few mosquito bites, no history of illness. Her serology testing is IgM positive and PRNT inconclusive. What should her management be? And so the purpose of this case is just to say that people who have inconclusive serology testing should be managed essentially the same as those who would test positive for Zika virus. So again, referred to a specialist, ultrasound every 3 to 4 weeks, and consider amnio, particularly if there's signs of malformation. This is my last slide. Just going to leave you with some sand art from an artist in Brazil. And again, it says Zika virus. If you can't see it up there, be alert. Back to Jonathan.
Thanks, Kelly. So I'm just going to move on. The next set of slides are actually prepared by a colleague, Doug Zyder, who wasn't available to present with us this morning, so I'm sort of presenting on his behalf. So I'm just going to cover a bit what are prevention strategies. Obviously, there's the personal protection measures that Kelly has gone over, and always that's a challenge in terms of getting compliance. Somebody who's heading off to get themselves a nice suntan might not be too interested in wearing long sleeves and stuff like that. But we just need to keep reinforcing that message. So things that you probably heard about in the news, there has been a program to release genetically modified adult male mosquitoes, and my understanding is that after they mate with female mosquitoes, they can't give offspring, or their offspring can't replicate. And that was a program supported by WHO. It has had some effect, but in the longer term, I guess it's not known what would happen. Like, some people have asked whether the Aedes aegypti may get replaced by something like Albopticus. And as I said, that has a wider range, so could there be more problems in the end? And we don't really know what this whole program is going to have in terms of impact on incidence of disease and infection in pregnancy, and how broadly it could be implemented. And then there's the mosquito vector control, and that's always a challenge, both doing larviciding and adult siding. I think they're both quite labour intensive, and there's quite a cost associated with those. But here's an example of what people have been doing. And just to remember that there are also dengue and chikungunya viruses circulating at high levels in some of these countries. So these activities would also help with controlling those viruses. And then with unpredictable rainfall patterns, it can be a challenge to eradicate breeding sites. Some people have looked at using DDT indoors. Again, it has been done in the past. This is showing you like just how crowded some of these locations are that we're looking at. Again here, and then if you're thinking about, like, we say, oh, get rid of any standing water, these people that live here are really going to walk around and eradicate every drop of water that's in the mud outside their house. So, there is a limit to what can actually be done. And then I also say in resorts, I think there's a lot of activities to do local treatment, and again, we're not sure how effective that will be in the end. From a Canadian point of view, we do have an Aedes called Japonicus that hasn't ever been documented to transmit the virus, but there is research ongoing at Brock University to see which Canadian mosquitoes could potentially have the virus replicate within them. In terms of a vaccine, obviously that would be the ultimate prevention. So we all know that Canada had a big part to play in the development of an Ebola vaccine. So the same researchers led by Gary Copinger at the National Laboratory were already working on a Zika vaccine. And he did say to the media that it could be up and running by year's end, but that may be a bit overly optimistic in that, like, there's so many stages to go through even if a vaccine works in the lab, like to get it to clinical use. And then types of vaccines. So there have been inactivated vaccines, live attenuated vaccines. They would be a challenge in pregnant women because obviously usually we don't give live vaccines to pregnant women. And then chimeras, we're using existing viral platforms, we're just changing some of the components. And then there's DNA vaccines as well that are being looked at. Sanofi Pasteur has a dengue vaccine that has been licensed in a couple of countries in the Americas, and it's thought that was actually based on the yellow fever vaccine that had been around for many years, and thought they could maybe do the same sort of thing again, where they just replace a couple of the genes targeting Zika virus. There's also a known West Nile virus investigational vaccine that's inactivated, and that could potentially be transferred to Zika virus. And we know that there's currently a Japanese encephalitis virus vaccine that's been around for many years, and the live attenuated yellow fever vaccine. Currently there's at least 15 groups doing research to develop a vaccine. Two promising ones are a DNA-based one in the US and an inactivated one in India. But we also have to think about, like, who would be the target populations. Like, maybe it would only be, say, women of childbearing age that really need to receive the vaccine, and you have to think about what vaccine type would be most suitable to them. It's going to take time because we'll need animal studies and then go through the different phases of trials. And then the other issue is with the association with Guillain-Barré syndrome. That has also been a recognised vaccine side effect in some vaccines, so we also need to monitor that closely. There is a WHO process to try and expedite vaccines for epidemics of global importance, and so that may help sort of speed things up. And I think the WHO has estimated that it would take about 18 months to get something going. So in terms of, just to finish up the last couple of slides, what do we need to be doing in the future? So we're working to better understand the epidemiology through serosurveys and looking at how much cross-reactivity is with all the flaviviruses. Like, one question I have is, what about West Nile virus that people in Canada have been exposed to? Currently they're saying that virus doesn't cross-react in the lab in a big way. And then better understand what is the symptomatic versus asymptomatic ratio of infections. And then a lot of work is going on to better understand the associations with microcephaly. We need to confirm the causal relationship and then better understand the incidence and the full spectrum of congenital malformations through both observational studies and animal studies. And then similar things for Guillain-Barré syndrome. And then I think there's a discussion about whether this virus should be a reportable disease, and then what would be the case definitions for surveillance purposes. And then, as I said, better understand what are the vectors beyond Aedes aegypti and albopicus. And we need to further refine our diagnostic tests and look for therapy. We didn't talk about therapy. Basically, it's supportive fluids, antipyretics, avoiding non-steroidals in pregnant women, avoiding aspirin in children. And so that's, we got through to the end of the talk. So I'll hand over back to Doug.
All right, thank you very much. I mean, that was a great presentation, a real pile of information there. There was a lot of a lot of great stuff, and I think we've got a few questions here that may have been answered there. And I'm not sure if I know Dr. Murphy had to leave shortly. Is she still with us?
Yeah, I'm still here.
Okay, so we'll try and get a couple of questions that I think were more directed towards your section of the presentation in case you do have to leave. So both of you did sort of talk a lot about sort of how long the virus lasts and what some of the recommendations are around conceiving and if you have a positive infection or if you've recently traveled. So we do have a number of questions around that, just mostly from the perspective of, if you do test positive for Zika as a woman, what is the risk to the future, to getting pregnant in the future, and what timing, how long should you wait before before you conceive, and the same with men returning and conceiving with a woman in Canada who's not infected, but the man is the one who's traveling. Just in general, what are the timelines that are being recommended that you avoid conception or conceiving?
Right. So, just to clarify, so the recommendations for if the woman is pregnant and her partner has traveled to an endemic area and returns. So one of the challenges is that different organizations have different suggestions. I think here in Canada, the public health, we're primarily saying 2 months, that men should use condoms for at least 2 months. But the CDC, and I guess what I'm saying in my practice is the CDC recommends that women, they would use condoms for the remainder of the pregnancy, which is a little extreme, but 2 months at minimum. I think as far as if a woman returns from an endemic area, they're saying at least 2 months prior to conception for her and for her partner as well. Jonathan, I'm just going to confirm that you agree with that.
Yeah, that's right. The Canadian document does say that for the male partner, if the woman's pregnant, to do it for at least 2 months, and it does say, however, they may want to do it for the duration of the pregnancy, which is what the CDC now is reinforcing. They put out another announcement yesterday encouraging that because of these extra 14 cases of sexual transmission.
Did you hear that? So because of the extra 14 cases, they're being overly, we're being overly cautious in pregnancy. Perhaps they should use condoms if their partner is pregnant.
Mm-hmm. All right. So this question is about sort of infection prevention precautions in a hospital. So a person comes back, returns sort of with, and is tested and has sort of active Zika virus. Are there any? Is there any presentation to a hospital in Canada that would require isolation, either an adult, a child, a pregnant woman, etc.? Is there anything that would require isolation or any advanced infection control precautions?
No, the only recommendation is that if somebody has acute symptoms and they're in an area where the potential vector mosquitoes are found, then they should be taking extra precautions so they're not bitten by mosquitoes during their first 7 to 10 days of illness, because that's the way they could transmit to others. Obviously, as I said, there's the risk of transmission from blood, but with standard precautions that would be taken care of, so there wouldn't need to be any extra precautions. The other thing is that people are advised not to, and their blood is not accepted for transfusion for 21 days after return from a Zika endemic area. That's another thing that is being done in the healthcare system.
All right. You did put up the map of from the World Health Organization about where the World Health Organization has identified Zika virus, and so as far as recommending people not travel, are you just recommending people not travel to whichever countries the World Health Organization has identified? In particular, someone is referring to the U.S. and traveling to Florida. Are you suggesting even southern U.S. people should avoid, or just limiting it to whatever the World Health Organization is suggesting?
Well, definitely the southern U.S. is not a problem at this stage. They have not had any endemic cases as far as I know. They've had cases, people that have returned travelers. I think around 82 are on their website, but they're all people that acquired the infection overseas. There's a theoretical risk of the virus spreading there because they have the Aedes albopicus mosquitoes. So at least in one documentation in Gabon in 2007 it was found there, so there's a theoretical risk, but so that should be fine. It's more a matter of, it's more the Americas that's really, that the advice is at present. Those other countries, there hasn't been large-scale transmission in other countries in Asia, in the recent year or so. So I think it's a matter of, if it was to emerge in any particular country in a big way, then there would be a recommendation to consider, but to reconsider travel to those areas. But currently it's in the Americas where it's circulating.
All right. Next question, I think is probably more for Dr. Murphy. Arlene's asking if you can describe the variation in maternal symptoms, sort of what's the range from mild, moderate to severe that people should be watching out for?
So the symptoms of Zika virus or the congenital abnormality symptoms? The symptoms of...
Yeah, I think she's referring to symptoms of Zika virus that they can either ask. Yeah.
Right. Yeah. So again, thankfully we have not had any cases here in Canada of pregnant women with the virus, but essentially we would be looking for fever, which, thankfully in most women are young and healthy who are pregnant. So having a clinical fever, that maculopapular rash, the conjunctivitis, joint pains are all pretty classic. And again, within, probably that 3 to 12 day range from exposure to that area.
The other thing to add is just that the infection is not like any more severe in pregnant women. That hasn't been found. It's just more the issue of congenital infections that's raised concerns.
And is there any risk from the infection itself to adults, or is it relatively mild illness in adults? It's really just the developing fetus that is at risk?
Yeah, essentially there's no significant risk to non-pregnant people, basically, both children and adults. So it's a very mild illness, except for that the very small risk of this Guillain-Barré syndrome that was mentioned. So if someone was a confirmed case, they would probably just be told, look, there is this very rare association. Obviously that hasn't been quantified exactly yet, and just so that if they were to experience any feelings of weakness in their lower limbs, then or whatever, anything like to suggest that they're developing weakness, that they should come and be seen immediately.
All right. The last question we have here, and that's sort of suggest for anyone else if you do have any last-minute questions, please do type them in as quickly as you can. But the last question that we have on the list here is regarding the Olympics that are going to be held in Brazil this summer. Has there been any discussion for increased international spread of Zika because of the upcoming Olympics?
I think it's still too early to know. Because these epidemics can be quite intensive and then settle down. I think we'll just have to wait and see in the coming months, like how intense the outbreak still is in Brazil. But there definitely will be obviously that risk of people that travel to the Olympics and then return to countries that have the Aedes mosquitoes endemic. Like I think parts of Italy and some other places in Europe do have the same mosquito. So there is definitely a theoretical risk of there being some spread after the Olympics.
All right. Well, I guess if nothing else, we can be thankful for our good Canadian mosquitoes. I guess I didn't think we'd ever say that, but so that is the end of the questions that we have from the audience. So before we wrap up, is there anything any sort of closing sort of key messages that you'd like to leave the audience with?
My message would be that Zika virus is not really anything to be significantly worried about. It's just more really in that group of pregnant patients, really, that need to really be taking the extra precautions and for the concerns that have arisen about possible congenital infection. But really, outside of that, people don't need to really be too worried about this virus.
And Dr. Murphy, any closing comments from you?
So I would reiterate that, although my population is pregnant, so
Yeah.
I would just say, conservatively, is that, I strongly think that, pregnant women should avoid travel to those endemic areas until we learn more about it, unless, just try not to expose yourself to that risk unless you would really, have a significant reason why you'd need to do that. So, good. Thank you so much.
Thank you.
Oh, yes. No, thank you very much. I mean, it really was an excellent presentation that put it, as the title suggested, into that Canadian context. Let us know there is an issue. It's not about Zika coming to Canada, but there is a certain patient population that does need to be concerned, and I think you've given us lots of good information and resources that we can go to at the. Well, that's a good question. Where's the best place to go to get more information? Is it obviously the CDC and the Public Health Agency of Canada? I'm sure would have information, but where would you suggest people go if they are looking for more information?
I think they probably are the two great sites to go to. PAHO, the Pan American Health Organization, has good information as well, and often a lot of the latest updates, and they put out reports intermittently. So do the World Health Organization. A lot of the information that I gave the update from a week ago about all the investigations of microcephaly had come from a WHO report. So I think that'd be the. If you're in Ontario, like that's where I am, but we also have information on our website. And as I said, people who are involved in laboratory testing, make sure you're aware with what the guidelines are in your province, what their documents are saying.
And the SOGC, or Society of OBGYN Canada, is soon to put out a document as well.
All right. And where would they find that? That will just be on the SOGC's website. Is that the best way to find that when it comes up?
Absolutely. Yep.
All right. Well, again, thank you very much. Excellent presentation, and thank you to the audience for joining us. Some great questions there. We did just have a question come in about will the slides be available for attendees, and yes, it will. The full recording of this will be available after the fact, which is always a lot of people find a great service. It is great when you can watch live, though, because you do have the opportunity to ask your questions and enrich the discussion, but we do make the slides available and the recording of the webinar available after the fact on the Knowledge Exchange Network. All right, next week on March 2nd, we will have another presentation, and it'll be our third presentation from the CIHR Chairs in Applied Health Services and Policy Research in Reproductive and Child and Youth Health. We'll be hearing from Dr. Jonathan Weiss and his colleagues to talk to us about the health of young adults with developmental disabilities across Ontario. Results from the Healthcare Access Research in Developmental Disabilities program, and Dr. Weiss will be joined by Dr. Barry Isaacs and Yanni Hamdani, who will present results from the Healthcare Access Research and Development Disabilities program, also known as HCARD, which focused on young adults with developmental disabilities in Ontario and was constructed by linking Ontario Administrative Health and Social Service data that was held at the Institute for Clinical and Evaluative Sciences. So it's a great opportunity for our colleagues that are interested in the area of transition of children transitioning to adult services, and particularly, obviously, children with disabilities, to learn a bit more information about what the status is for that patient population in Ontario, at least. So lots of great stuff coming up next week, and certainly check the CAFC Presents website, or CAFC website, and the CAFC Presents webinar calendar for other presentations that we have coming up. And hopefully we'll see you back here next week. Bye, everyone.